I'm Sloan Manning, a family physician in Greensboro, North Carolina. I am a psych PCP Corner advisor, and we wanted to talk a little bit today about the opioid crisis and general to maybe specific strategies for addressing the crisis in our practices. What large organizations are doing, what the government institutions are doing, what we can do as providers, just several things like that. The first thing that comes to mind is actually just the amount of information that's actually available to providers very, very easily. And the first place I would go to get basic information on helps would be the CDC CDC site. They have lots of information on best practices for opioids, when to avoid opioids, when you can get in trouble with opioids, what some of the sort of features or hints or warning signs of opioid diversion and abuse are. There's even a smartphone app that allows you to reference in your hand what appropriate doses are, what potentially dangerous doses are, when the combination of benzodiazepines and opioids becomes a higher risk for accidental overdose and deaths. I think most of us realize that in a number of states around the union, accidental deaths to opioid overdoses have surpassed motor vehicle accidents in the last few years as causes of death. And I have contacts and patients in some of the law enforcement agencies in our area in North Carolina, and it's just a terrible problem with outside narcotics coming in, heroin laced with fentanyl and carbamfentanyl. It's just a significant issue that we all face, and we all need to have in mind where our own limits will be, what strategies we'll use, and who we'll partner with in order to get this done. Because one of the things that the CDC recommends, in addition to giving guidelines about avoiding narcotics when narcotics are not necessary, using alternative means for pain control, one of the things the CDC recommends is the pharmacist on the front line. And one of the things that we have used for years, and our pharmacists in our area have used, is phone calls. If we're suspicious, if we're not sure, if we're getting confused or the patient's giving confusing information about refill dates and who prescribed what when, we'll pick up the phone to the pharmacy and verify the information. The state database that now connects to many state databases for controlled substances dispensing is available in our electronic health record, and in the next version of our record, which is we use Epic as our particular EHR, that most recent profile for the patient who is on chronic opioids or controlled substances will be immediately brought into the visit dashboard so that we immediately have information on who else might be dispensing, when prescriptions are filled, and what best practices are. We've set a standard now, and this is in alignment with the CDC, that even people at low risk on chronic opioid or controlled medications, a yearly drug screen is probably best practice to make sure that no other medications are involved and that dangerous potential combinations of medications are not being used by patients. Let me just read a couple of things from the CDC recommendations talking about when to initiate or continue opioids for chronic pain. Just a couple of highlights for you. Number one, opioids are not first-line therapy for chronic pain. Non-pharmacologic therapies, physical therapy, massage therapy, non-opioid pharmacologic therapies, behavioral treatments such as cognitive behavioral therapy, interventional treatments from pain or anesthesiologists, pain providers or anesthesiologists are certainly there. Making sure that the goal for pain treatment and reduction is actually discussed openly with patients who are on these medications. There's even a recommendation in the CDC guidelines for motivational interviewing as a way of establishing a collaborative communication with patients to get this job done. Discussing risk and benefits, periodic reevaluation, using immediate release opioids when starting, using lowest effective dose, and again, generally avoiding going above 90 morphine milligram equivalents per day. Certainly 50 would be an even safer level, and particularly 50 if the patient is on a comorbid or a co-administered, benzodiazepine. But short durations for acute pain. In many of our minor medical settings in our area, we actually prohibit the prescription of narcotics by our advanced practice clinicians and physicians, except under very, very rare circumstances when it might be 1 or 2 days of therapy that might be necessary in transition to a specialist. In our urgent care facilities, the state law has us at a limitation of 5-day prescriptions for acute pain, and repeat visits required if anything else in the area of narcotics seems to be reasonable and necessary and has a benefit versus risk profile that's positive for the handling of acute pain. So we want to stay on the safe side of dosaging. We want to monitor. We want to set expectations, evaluate benefits and potential risks frequently, and then use strategies to mitigate risk. We've already mentioned talking actively and collaboratively with our pharmacist colleagues, reviewing prescription drug monitoring programs. And again, almost all states have these, and in many states, those prescription drug monitoring programs are interrelated. I know in my electronic health record, I can query North Carolina's database, but if the patient I know travels frequently, has family other places, or lives on a border with another state, I can query Virginia, South Carolina, Florida, Georgia, Tennessee. All of those patient monitoring sites are available. I mentioned periodic urine drug testing, avoiding concurrent opioid and benzodiazepine prescribing, particularly at MME dosings of 50. And again, offering treatment for opioid use disorder. It's just inevitable that as we have these conversations, we will run into individuals who are frequently in our office who will have at least signs or symptoms of having lost control of their opioid use and be diverting or getting prescriptions or seeking prescriptions from other providers, early refills from us, those kinds of things. So awareness, collaboration with our colleagues, all of those kinds of things are there. The North Carolina Board of Medicine in the last few years has issued a number of cautionary statements and guidelines. The board in our state is actively monitoring individuals and practices that are practicing in the higher dose ranges for opioid medications. And some of the principles that are taking place is that they're actively monitoring people who are, if the prescriber falls in the top 1% of those prescribing 100 milligrams of morphine equivalents per day per patient, if the prescriber falls in the top 1% of those prescribing 100 MMEs per day and the patient also takes a benzodiazepine, or if there have been 2 or more patients who have died in the preceding 12 months due to opioid poisoning, that triggers an automatic audit from our state board. Many other state boards are also taking an active role in this way. Our EHR, in the new version that's going to be uploaded into our system in just a couple of weeks, has a brand new section on best practice for opioids. The opioid screen, or a screener for opioid risk, is actually in the EHR and must be completed when patients are on chronic opioid therapy. And if that patient would appear to benefit from longer-term treatment with opioids, every 90 days, the state database has to be queried. There has to be an active opioid use agreement in the chart. The drug screens pop up in smart sets with it. We just have to endorse by accepting that. HIV and hepatitis C screenings come up periodically for these patients too, because it's now well recognized that opioid abusers are at higher risk of HIV and hepatitis C, even though the history you get in the office may indicate minimal risk. An active screening protocol is really preferable for these patients. So in our opioid best practice, if you're prescribing an opioid for 8 or more days, the flow sheet has to be completed on the patient. There is information in the risk assessment about a family history of substance abuse, a family history of illegal drug use, a family history of prescription drug use, a personal history of substance use, a personal history of illegal drug use, an age between 16 and 45, a history of sexual abuse, a history of mental illness, including depression or schizophrenia or bipolar disorder. All of those factors go into an opioid abuse risk assessment. And then the provider has to acknowledge that that risk has been discussed with the patient, that the opioid use agreement has been signed, that the database for monitoring has been reviewed, and that the patient is going to be monitored regularly in that case. And again, in my practice, I probably have 4 or 5 individuals, some of them that I've been seeing for 10 or 15 years, who have been taking longer-term opioid medications for pain relief and appear to continue to get more benefit than they incur risk in doing so. But I have been having discussions with them about how best practice is changing, and in the last month, I have surprised, in a way, some of my longer-term patients with an invitation to go have a drug screen, but not without warning them that that was going to take place. So I spent a few months telling them the rules were changing, and then in the last couple of months, I have been able to announce the rules have changed. And now, in addition to this information about risk of drug abuse or opioid abuse or the risk-benefit calculation, I now need evidence that you are taking your medicine and not taking other medicines that might put you at risk. So it's a very, very broad approach that looks at recognition of opioid abuse as a national problem, looking at general principles of good care, at collaborative care with our fellow providers, including pharmacists who are dispensing these medications, and also making sure that patients are getting the best care in the best place. There are some people who come to my practice who would be asking me to prescribe these medications for which I feel not very comfortable. And in those situations, I will defer and refer into pain clinic settings to make sure that they get the best care and the best practice around those kinds of cares. So individual decisions will be made, and we'll try to keep prescription dispensing short and appropriate and keep everybody safe because the danger is there, and I think we all recognize that based on the recent news and information we've gotten from all kinds of medical authorities. Thanks.